There's a reason why HIV is the only disease condition that has an entire UN program dedicated to it, UNAIDS. There's a reason why HIV is the only health condition where you have an entire federal government agency and state agencies looking after one disease. And that's because it affects the youth, it affects young people, and it affects countries' GDP. It was challenging, but it was also quite what would I say, satisfying in a way. It's not easy bringing disparate groups together. Here we're talking about partners that have been funding the response. We're talking about implementers that have been delivering programs. We're talking about the people living with HIV for whom we're there for, really. We are also talking about government. And we had to practically drag people sometimes kicking and screaming to work with each other. But I think, to me, just like with everything else, I usually tend to look at the outcome. Is it worthwhile? Where are we trying to get to? How do we get there? And how do I get people to buy into my idea or our idea in terms of where we want to be? And with the HIV survey, it was really pretty straightforward. What did we want to do? We wanted to rebase the epidemic. We wanted to know the prevalence of HIV in the country. We wanted to know the incidence of HIV, the new infections that are happening. And we wanted to have a clear idea of how well we were performing as a HIV response. So it was collectively in our best interest. And I must say, three things actually helped. Funding, having good funding, and I must really credit our funders, really, the US government and Global Fund. They put $91 million into this. That's almost a quarter of what they spend on HIV per year. They put into the survey and got it done. And then secondly, the engagement of our technical partners. Our technical partners actually did a pretty good job. Initially, at the beginning, the relationship was a bit rocky. There were a lot of things that we thought were not going right. Oh, this is not how you do this, etc. But at the end of the day, they were vindicated. They went very quick, they went very efficiently, and they got to the right people to do it. And then thirdly, I think what really helped was the capacity of the country to be able to deliver on technical things. You underestimate this, but if you go to other West African countries, for instance, or other parts of Africa, you will find that the skill base is actually pretty low. You would advertise for a technical position, and sometimes you wouldn't find anybody who fits the picture. Come to Nigeria and advertise for anything, you'll get millions of people, and millions of people with actually the right skills, with the right knowledge, and also with the right attitude to work. We've had people in the survey that put their lives at risk because of the survey. We've had people who were actually, a whole team was almost kidnapped in the Northwest when we were doing the survey. And we had teams that went all the way to the Northeast, places like Chibok. We had people that went into areas that were considered inaccessible. Within 24 hours, collected the data, did the survey, came out all on the same day. And we really must be grateful to this group of Nigerians because they've shown really how patriotic they are and how important the job was. And they got the job done. In 10 years' time, or maybe 15 years' time, Ada, you're not going to have PEPFAR running the program. You're not going to have Global Fund. Our friends now, they would have disappeared by then. But the people living with HIV, the person diagnosed now with HIV, will be around in the next 10, 20 years. So who's going to look after him? So government, as government, we know our responsibilities. We know that this is going to happen, and we've already started planning for it. So I gave you the idea, the information about Taraba and Abia, where we've now fully accommodated the people that are on treatment. And Mr. President has also directed that every year the government of Nigeria should add 50,000 people on their program, okay? And that's going to happen. But the bigger issue has to do with who will take up responsibility for the 1 million plus Nigerians that are on treatment, courtesy of Global Fund and PEPFAR. to be able to fund that properly, we have to have 2 or 3 things happening, okay? The first one is that the health budget in the country has to increase. At the moment, it's about 300 and something billion, I think 320 billion or so. So that's less than $1 billion US. If we are going to accommodate the 1 million plus Nigerians on treatment, we'll be taking more than 60% of that health budget to look after the 1 million. So the only way we can accommodate that is you grow the pie. If you grow the pie, then you'll be able to get a larger portion. So that's one thing that has to happen. The Abuja Declaration in the long term has to happen. The 15% recommendation for health. Because as government, we are improving the infrastructure in the country, we are improving the economic base, etc. And hopefully we'll be looking at health and education next. And health and education will have to start taking up a greater fraction if we really want the development that we have to continue to be sustainable in the long run. So that's one thing that needs to happen, grow the pie. Second thing that needs to happen is identify alternative funding mechanisms and routes. So health insurance, for instance, universal health care. My goal in the long term is really to integrate HIV into the health system. This situation where you have vertical HIV programs is not the best for the country. So if we have universal health care, if we have health insurance, where today if you're diagnosed with HIV, your health insurer would look after you, is really a goal that I hope I'll be able to achieve over the next few years. We are not saying that the health insurance scheme should take up the 1 million plus that are already on treatment, but we're saying at some point we have to say HIV is now part of the health insurance scheme. If you are introducing a health insurance scheme in your state, or a contributory scheme in your state, or even at the national level, it needs to accommodate for HIV. So that's the second thing that needs to happen. The third is to bring down the cost per unit of delivering HIV care. How do you bring down the cost? Local manufacture of HIV drugs. Generally, the cost of generic drugs is coming down as well. So as the cost comes down, we are now having new drugs coming in like TLD, tenofovir, lamivudine, dolutegravir. It requires fewer blood tests, therefore less cost in terms of driving that. So if you can bring down the cost by generics, by local manufacture, and also by making it easier for facilities to look after patients. So one of the main cost drivers is we use a lot of doctors in our clinics or trained nurses. You don't need that for HIV. HIV is so simple that even you, Ada, can open up a HIV facility. It's all about diagnosing and putting people on treatment, and the drugs are pretty much straightforward. So what we call trying to have differentiated care models, where some of these drugs are available at the pharmacy level in the local communities. So if you have HIV, you've already been accessed your facility, you've been diagnosed, you've been placed on treatment, then the follow-up drugs, instead of going to a facility every month to have a drug given to you, we stretch that so that you don't need to be seen until maybe every 6 months, and then if you run out of drugs, you can go to your local chemist to pick up your drugs. And even within the facility, community healthcare extension worker should be able to see you and to give you your treatment. So bringing down the cost overall and then pushing it into the health system so that you have general medical clinics. You stop having dedicated HIV clinics, dedicated HIV facilities, dedicated HIV laboratories. It is not the right way to deliver healthcare in our system. It's very expensive and it is not sustainable. And over the long term, we, as government, we will be pushing towards trying to mainstream HIV healthcare, so that as our partners that have helped us over the years exit, we'll be able to say, yeah, we have now grown up, and we will start looking after ourselves. We are now adults, in a way. Yes, there's always a silver lining in everything. I think the medications that we are having for HIV are more effective than they've ever been. They are very tolerable. They're taken, most of them are one tablet once a day. Over the next 2-3 years, we expect injectables, what we call long-acting injectables, to come in. And these will be injections that will be given once, and then we say bye-bye to you and see you in 3 months or 6 months time. You come back and we give you another jab. So essentially we're starting to normalize the process of people being on HIV treatment, having normal lives, being able to do their normal routine without having to think about having HIV, or without having to think about taking a pill, etc. And I think another silver lining that is on the cloud is, in terms of the epidemic itself, I am more confident than ever that one day and very soon Nigeria will achieve epidemic control of HIV, just like the rest of the world is rushing towards epidemic control. I cannot give an estimate to say 5-10 years, but I expect that HIV will cease to be a major public health problem, not only in Nigeria, but actually in sub-Saharan Africa, as more and more people get diagnosed and as more and more people get placed on treatment. Because the more people you have on treatment, the less the transmission. Once you're biologically suppressed, what we call undetectable equals untransmittable. You will not be able to transmit the virus to your partner or to your child or to anybody else. So that's the silver lining. I'm not going to talk about a HIV cure, but science is making good progress, and in the coming years, generations to come, I am sure science will sort out that problem once and for all.